And so, Dr. Wooster, thank you again for bringing us that very interesting case. I think very well executed, taking care of a sick gentleman and avoiding open surgery, which was definitely, in my opinion, fraught with disaster. So thank you for that. And next, Dr. Humphries, the floor is yours.
So today I brought a case of a 73-year-old gentleman who has a type 4 thoracoabdominal aneurysm. And, in these cases, we're doing physician-modified grafting, which I know you also do. In this case, he's got the angulation of his iliacs made it to where the grafts needed to land. We really wanted to come up with the main body on the left side, but the iliac on that side is very stenotic, highly calcified in that region. So when we did this case and when we looked at it, the thought was, are we going to need to do some type of a conduit, or could we avoid that? We really prefer to come up percutaneously in these cases, but it requires a large device. So when we're doing physician modified, you're looking at a slightly bigger device than what we would normally use for a standard EBAR. So you can see in this case where all that calcium is on that left common iliac artery. What we did is, you can see in the next pictures, which are the angiographic images on that.
So Dr. Humphries, before the availability of the L6, what was sort of your approach in cases like this? You mentioned, I know people talk about crack and paving and such. It always makes me nervous, like putting a fresh stent and then driving a graft right through.
Absolutely. So in this case, whenever one option is to come from the other side, but then you may not land your device properly. You may not be able to get into the vessels that you want. The other alternative is, of course, we would potentially do a conduit in this. So we would do a retroperitoneal incision, go in, that adds to the case.
Significantly.
And it adds to the case time, it adds to blood loss. And for some of these patients, they want to be able to come in and have this case done and then go home the next day. And so they don't want to be in the hospital. Are they going to have an ileus? How are you going to be able to access this vessel? Some of our patients have had previous surgeries. And so it makes it really challenging.
And, clearly the M5 was available. And in my opinion, the L6 is a clear improvement because you can more safely, in my opinion, get to these larger vessel diameters. I don't know if you...
Absolutely. So I like the L6. I like the energy profile of it compared to the M5. So it puts out a more even kind of energy profile, and you can actually concentrate the lithotripsy in those areas of calcification. For the common iliac arteries, the common iliac artery isn't that long, so you don't need something as long as the M5, and you can really focus right in that region. So, and then you can see here after the devices, or after the procedure, a great result with both sides open, no evidence of stenosis in that common iliac artery on that left side. It really took the device, and we were able to do all of our work. So.
Not only that, this is technically an excellent result, but you also worry about limb inclusions. And, by treating these up front, you're probably, long term, these patients are doing much better.
Oh, they're doing great. I'm old enough to remember when some of these endovascular devices came out, and you would be going through tight lesions, and Tim Tudor almost always would put additional stents in the endograft limbs. And you don't have to do that anymore because you're opening this up with a device that's going to break that calcium. You can just put your devices up. It's going to fully expand. And so A, it saves cost, but B, it's just a better procedure all around.
Yeah. Let me ask you, how are you sizing it when you're doing it for the large bore devices like this? Are you sizing to your native vessel, or are you sizing to the device that you have to put in?
I'm trying to decide. I usually will size to the native vessel. So I really want to open that vessel up to what is going to be the maximum. So I'm looking at a piece of the vessel that's in the proximity to where the tight area is, and finding out how big that vessel is. So I like oversizing. That's the whole point of this. It's a vessel prep. So I oversize a little bit in order to get great wall apposition. I think that's a really important thing. I try to remember this is a vessel prep device. This is not necessarily something to be afraid of. So you want to get good wall apposition so that you can break up that calcium.
Yeah, I think this is a very important point. I think for the device to be successful, you've got to get that vessel apposition. And in fact, I think with the L6, I've been sizing this even 1-to-1 or even 10% more, almost like, just to get that better apposition, because you are doing the lithotripsy at a lower number. You're going to 2 millimeters of mercury instead of 4. So
correct. So the nominal in this device, it's a lower inflation. you're starting to do your lithotripsy at 2 atmospheres. I'll usually do a couple of cycles at 2 atmospheres, and then I can go up to 4. Sometimes in between there in some way, if I feel like, I'll see the calcium crack and I'm like, oh, go up just a little bit more. I try not to stay on the fluoro the entire time, but sometimes it's fun just to watch that.
That's
You're like,
exactly.
ooh, ooh.
But that's the one, so when I first started using this, it's a true story. It's like, I remember doing this in an SFA, and you had to balloon up, and it's just a profile of that calcified vessel. And you start doing the lithotripsy, and you see the balloon go like,
Open
what's
up.
happening?
Oh yeah, very
Right?
rewarding.
What's happening? I know.
I think that actually, yes. So the residents, other faculty that haven't used it, seeing it open up, and that's really where you saw more people starting to use it.
That's
There
right.
were a few early adopters who were using it, and then whenever you could see the expansion of this into all these different spaces, like large access here, I think you get a lot more people wanting to use it.
Off the record, but I was a very slow adopter for this. I think the first time I did it to the second time I used it was like maybe a 6 to 9 month period, because to me, it just sounded like, what is this thing? Right? It just sounds made up. But once you start using it, I just feel like you can't get enough of it. Like, the outcomes I use it a lot in the tibials, and I find it very, very effective in that space.
Well, yeah, if you look at the Disrupt trials that they've done, they've had the open label and they're now enrolling in the BTK trial. When you look at those trials, there's a low rate of dissection, there's a low rate of embolization. And that's one of the nice things about this device is rather than, traditional atherectomy or causing these different complications, you let the device do the work. And if you oversize it, the impedance of calcium and the impedance of the vessel are totally different. And so it breaks up that calcium, it doesn't harm the vessel, and so it's a really, really nice.
And it's also the intima versus the media where it acts upon. And I'll be perfectly honest, when before the use of lithotripsy, you'd be doing these heavily calcified iliacs, and my major concern always, even though I used covered stents, was risk of dissection, risk of rupture. I don't know. I feel much safer with using this as you said, a vessel prep.
Yeah.
I totally agree with that. And the oversizing can't be emphasized enough. One of the reasons I ask you the question is I think this has changed the way we think about how to deliver large bore with a prep. Historically, I would get the balloon size to the device rather than the native vessel. I wanted to go just big enough to get that device up. Whereas now, if you actually size it to the vessel because you're not as worried about a perforation, a rupture, a dissection, that safety profile lets you get a much better result and something that's now going to actually be a durable result rather than this patient being left with a still stenotic iliac, a dissected iliac. You can go up and it tracks your device better.
Yeah, and going back to
you don't have to go one-to-one to the device. Go to the vessel.
Going back to the Disrupt trial, the risk of perforation was nearly zero, if not zero.
It was zero, yeah. In the open label study, they had slightly more complications, especially a slightly higher risk of dissection. I think it was 1.7%. That's pretty low. So
right, plain balloon angioplasty, I would submit to you, that's like what, 50%, 30%?
Well, and all these patients would have been excluded because of the heavy calcification. These patients aren't in the trials, so you don't get the real numbers for them because nobody would do these.
I think that's a great point. I think you're selecting these very heavily calcified, high-risk sort of folks where, traditional therapy may not be as effective as it would be with lithotripsy.
And you're seeing great outcomes in high-risk patients. That's the thing to keep in mind here.
Yeah. Thank you again for bringing this very challenging case. I think, your planning clearly was well executed and the patient clearly had an excellent result. So, just trying to sum it up, I think, how has this changed your practice in terms of with the availability of the L6 now? Have you changed anything, particularly with regards to stenting these lesions, or do you see a greater applicability for this?
I do. So earlier we talked a little bit about the crack and pave technique whenever we were doing access for FEVAR or EVAR. You have to go in, you have to crack that vessel, and then you stent it so that in case there's a problem. Now I feel much more comfortable just going in and actually prepping that vessel to where we can put our device in. For these kind of lesions where it's for endovascular graft, you don't have to put a stent in before you actually do your procedure, and you get better expansion of your endograft.
Dr. Wooster, I'd pose the same question to you.
Yeah, similarly for these large bore access cases within the iliac, historically we would balloon, stent, then do our procedure. And now with the ability to expand safely without the fear of rupture, you can get rid of a layer of stent get rid of the cost of an extra stent, streamline your procedure so that you're not doing as many steps before you get to your end result. And for the common femoral, it's expanded our ability to get percutaneous access in these patients who otherwise would have required a surgical cut down. And there's really strong data that shows that's beneficial to these patients.
Okay. Well, thank you for those comments. I would like to thank Dr. Humphries and Dr. Wooster for joining us today in this very interesting conversation. I think, in my own practice, I've seen increasing use and I feel comfortable, and I think it's it's safer for the patient. So with that, thank you again. Thank you, Shockwave, for putting this together.
It was
Thank
nice
you.
being here.
Yeah, it's great.
Appreciate the time to go over the cases.